Hello everyone, welcome to our next video on the antipsychotics. In continuation with the previous video, we cover dopamine hypothesis of schizophrenia, serotonin hypothesis of schizophrenia, glutamate hypothesis of schizophrenia. In this video, I am going to cover the typical antipsychotics and atypical antipsychotics, their clinical uses. In the next video, I am going to cover the adverse effects and the summary, because the adverse effects it will take very long time. So in this video, I am going to focus the classification and the clinical uses. All right, let us start. The classification, you can do the chemical class and also the based on the potency. The chemical classification mainly the typical antipsychotics, we also known as the first generation antipsychotics or older medications. So the chemical class like phenothiazines. So because why the chemical class important? Sometimes in the exam they may ask you like the phenothiazines or butyrophenols. Okay, so make sure you know those chemical class. Not everything, at least phenothiazines, butyrophenols are important. The phenothiazines, chlorpromazine, thioridazine, flufenazine, where butyrophenones, haloperidol. And also in terms of potency, so how to determine the potency? It depends on the dose. If you take example of two medications like chlorpromazine or haloperidol, the potency is different. That means the two drugs produce the same response at the various doses. If the drug is require higher dose, okay, so higher dose to produce antipsychotic effect, that means chlorpromazine is a lower potency, whereas the haloperidol high potency means less dose. So less dose produce the same response that is produced by chlorpromazine, right? So same response, the only difference is the dose, that is the potency. Okay, the atypical antipsychotics, these are second generation newer medications, and these are clozapine, olanzapine, risperidone, quetiapine, ziprasidone, aripiprazole, iloperidone, lusaridone, asenapine. So these medications, in addition to, so okay, let me give some high-yield point here. The typical antipsychotics predominantly blocks the D2 receptors, whereas atypical antipsychotics, in addition to D2 receptors, they also blocks 5-HT2 receptors. So typical antipsychotics mainly effective positive symptoms of schizophrenia, whereas atypical antipsychotics, they are effective both positive symptoms as well as negative symptoms of schizophrenia. So that's a therapeutic response, right? So, and also the atypical antipsychotics, usually drug of choice to control the schizophrenic positive negative symptoms. Whereas typical antipsychotics, they are not effective negative symptoms. So they mainly effective for positive symptoms. Sometimes they worsen the negative symptoms because they block the D2 receptor. I'm going to explain the rationale in the next slides. Okay, in addition to these receptors, they also block like muscarinic receptors, alpha receptors, and histamine receptors. So that may cause some other adverse effects. Okay, so here is the risperidone, that is atypical. I think maybe my picture is blocking that. And thioridazine is not available in US because it's a lot of adverse effects. So that is what it's not preferred. The next one, the mechanism of action. The mechanism of action of antipsychotics, they mainly blocks the D2 receptors, where in the mesolimbic area, you recall the dopaminergic pathways, mesolimbic area from the ventral tegmental area to the mesolimbic, right? So that is the nucleus accumbens, right? So nucleus accumbens limbic system, so dopaminergic blocking that produce antipsychotic effect that reduce the hallucinations, delusions, disorganized thinking, disorganized speech. So that is by blocking D2 receptors. So what is the G protein couple here? So here, this is a GI mediated. So there is a nice YouTube video I created 6 minutes for the G protein coupled receptors. If you watch that video, you can easily identify the second messengers and GS, GI, GQ, okay, various medications. So it is easy way to remember like MAD2 SOR inhibitor, GI. So that means D2, A means alpha 2, M means muscarinic 2. Okay, so when you block D2, antagonize antipsychotics block D2, that may blocks the GI, so that increase adenyl cyclase, increase cyclic. That is the mechanism. So that action in the mesolimbic area that contributes to decrease the hallucinations, delusions of the positive symptoms of schizophrenia. All right. Whereas atypical antipsychotics, in addition to dopaminergic blockade, they also block serotonin receptors, especially 5-HT2A and 2C. These are presynaptic. So these are effective both positive and negative symptoms of schizophrenia. So atypical effective both positive and negative symptoms. Why it is effective in negative symptoms? So if you recall negative symptoms, that is a mesocortical. So mesocortical area. So in this, so you have the projections from the ventral tegmental area to the prefrontal cortex dopaminergic projection. In the schizophrenia, there is a decreased dopamine that leads to negative symptoms of schizophrenia. Whereas 5-HT2 blockade, for example, this is a presynapse, this is a postsynapse. So in the presynapse, you have 5-HT2A receptor and 2C. If you block this in the mesocortical area, so it increases the dopamine release in the mesocortical area. So that is why it decreases the negative symptoms. So that is what atypical antipsychotics, by blocking presynaptic 5-HT2A, 2C receptors, that increases dopamine release in the mesocortical area. That is what they are useful to manage negative symptoms in addition to positive symptoms. And one more difference you must know, typical antipsychotics, they block 100% of dopamine receptor. That's what they're more prone to extrapyramidal side effects. Whereas atypical antipsychotics, they have like 50 to 60% of dopamine 2 blockade, less extrapyramidal side effects. Okay. Whereas aripiprazole is a partial agonist at D2 receptors. All right, let's talk about pharmacokinetics, because in the schizophrenia management, you need medications, oral route, sometimes you need medications, long-acting intramuscular parenteral injections. So it's very difficult to convince psychiatric patient to take pills, right? So sometimes you need injections, parenteral administration. So that is why, so you have, so antipsychotics you can give by both oral as well as parenteral. All right. So oral and parenteral route of antipsychotics, it is available in both forms. All right. So you can give tablet form or you can give by injection form, and also they readily crosses the central nervous system, right? Because they have lipid soluble nature. That is what they easily crosses the membrane, the blood-brain barrier, enters the mesolimbic, mesocortical, nigrostriatal, tuberoinfundibular pathways, right? And also the parenteral preparations, mainly flufenazine and haloperidol. So you can give the intramuscular injection if the person is not able to take oral medication. All right. So in addition to the dopamine, so dopamine mainly the D2 receptors by typical antipsychotics, serotonin 5-HT2, that is by atypical, and also they block anti-HAM. So that means H1 alpha 1 M1 receptors. Okay. So here you can see this picture. This is the log dose, x-axis doses, 1 and 10, 100, 1000, 10,000, the log dose, and this is the y-axis. You have affinity for the D2 receptors. When the medication close to y-axis and also less dose produces almost a 50% response, right? So the drug is very close, means it's very small amount, it is a more affinity, like haloperidol and flufenazine, thyroidazine. These are very potent medications. Whereas clozapine and olanzapine, chlorpromazine, these require higher dose. So that means less potent. All right. And also, in addition to dopamine receptors, they also blocks the various other receptors. For example, chlorpromazine blocks alpha 1, then serotonin and dopamine. So that is why chlorpromazine, it may cause hypotension. We know that the blood vessels, you have alpha 1 and beta 2 receptors. When you block alpha 1 receptors, so you may have decreased total peripheral resistance and vasodilation that may cause decreased blood pressure and also reflex tachycardia, right? So that's a alpha blockade, orthostatic hypotension, postal hypotension, or impotence, or the problems in the ejaculation. So these are the alpha 1 blockade. Whereas haloperidol, so mainly dopamine, highest extrapyramidal side effects, motor problems, and alpha blockade hypotension. And also histamine, least one. So what happens when you block the histamine? Histamine antihistamines, they cause sedation or increase appetite, weight gain. That is the histamine effects. Clozapine, atypical second generation, mainly D4, then alpha, then serotonin and dopamine. Whereas olanzapine, mainly serotonin. Aripiprazole, partial agonist dopamine and antagonist at the serotonin. Alright, and also the quetiapine is a mainly histamine, alpha and muscarinic than dopamine. So what happens, the muscarinic blockade? So that leads to anticholinergic, atropine-like effects like dilatation of pupil, dryness of mouth, and tachycardia, constipation. You see the parasympatholytic, anticholinergic. That means you close all the faucets, constipation, urinary retention, right? So that is the anticholinergic. So this is a table from the Katjang textbook of basic clinical pharmacology. So here you don't need to memorize. So here just analyze the which one is the highest potent, which is the high extrapyramidal side effect, which is a more sedative. For example, so in this table you can see the haloperidol is a very high extrapyramidal toxicity. That means the movement problems, Parkinsonism, dystonia, akathisia, extrapyramidal side effects, okay, movement problems. So whereas the least the extrapyramidal side effects, you can see the second generation like olanzapine, quetiapine, or piprazole, ziprasidone. Highest sedative like chlorpromazine, the least sedative like risperidone, clozapine, okay, and haloperidol. So that's what you can compare. Or clinical potency, high potent drugs like haloperidol, commonly used. The clozapine, we keep that is a reserve for the resistant cases because it has a lot of toxicity, but it's a very broad spectrum, very effective medication. All right, so in this table, we can see what happens when you block each receptor, what is the consequence. That is very important for your board exams. So they may give the case, they may describe the patient is a dizziness and orthostatic hypotension and reflex tachycardia and extrapyramidal side effect. So for example, you take this one, the first one, the patient is antipsychotic medication, develop all these. They may ask you what receptor blockade is responsible. So then you can easily say this is a blockade of alpha 1 receptor, right? So alpha 1 blockade causes the attacks on the GQ receptors, decreases phospholipase C, decreases calcium, decreases contraction, decreases total peripheral resistance, vasodilation, postal hypotension, reflex tachycardia. Easy, right? So then blockade of dopamine 2 receptors, that is important for the therapeutic response. Where it is blocking? It blocks the mesolimbic area. So where is the mesolimbic area? That is the dopaminergic projections from the ventral tegmental area to the the mesolimbic, so ventral tegmental area to the nucleus accumbens, right? So that is a mesolimbic area, limbic system. So here dopamine receptor blockade that alleviate the positive symptoms. What are the positive symptoms? Hallucinations, delusions, illusions, disorganized speech, right? So that is a mainly controlled by D2 blockade in the mesolimbic area. It is a mainly control positive symptoms. The problem is if you block the D2 receptors in the nigrostriatal pathway, right? So nigro substance, the dopaminergic projections from the substantia nigra to the striatum important for the motor coordination. So when you block dopamine receptors in that nigrostriatal pathway, that may lead to extrapyramidal side effects like akathisia. So akathisia means so they cannot sit in one place. So they are motor restlessness and feel compelled to move and shuffle their feet and they cannot sit quietly. So that is akathisia and dystonia. So dystonia means a state of abnormal muscle tension, often affects the neck and facial muscles, including the tongue, pharynx, larynx, and eyes. The patients with the dystonia can experience severe reactions like oculogyric crisis, a condition called eyeballs become fixed in one position, usually like upward, and also the glossospasm, tongue protrusions, and this is called as and also torticollosis. The torticollosis means a contracted state of cervical muscles, the protruding twisting of the neck, and also unnatural position of the head. So those reactions are very painful, and pharyngolaryngeal dystonias, they are life-threatening. So these are the mainly extrapyramidal side effects and pseudo-Parkinsonism because when you block the dopamine receptors in the nigrostriatal pathway, that may cause drug-induced Parkinsonism, the signs and symptoms like rigidity, bradycardia, and tremors. And elevated prolactin. So this is the mainly blockade of dopamine receptors in the tuberoinfundibular pathway, right? So that is a hypothalamus, the dopaminergic projections from hypothalamus to the anterior pituitary, hypothalamus to anterior pituitary dopaminergic projections, that dopamine blockade, so that dopamine usually inhibitory effect on the prolactin secretion. So when you block dopamine, so you take out that inhibitory action. So that may increase the prolactin. So that is called hyperprolactinemia, gynecomastia, menstrual disturbances, and infertility and galacturia, the leakage of milk through the breast, and menstrual problems and infertility. Okay, and also uh, uh, okay, so that is hyperprolactinemia. So that is a blockade of dopamine receptors in the tuberoinfundibular pathway, endocrine problems. Okay, so then blockade of D4 receptors, that is mainly in the mesocortical area, that alleviates the negative symptoms of schizophrenia and also decreased incidence of extrapyramidal side effects. Okay, and blockade of histamine receptors. I already mentioned histamine blockade that leads to drowsiness, sedation, and increased appetite and weight. That is a histamine blockade. Blockade of muscarinic receptors like atropine-like effects, anticholinergic. Atropine-like effects means dryness, dry as a bone, right? Beat as in red. So like that, so the like blurred vision, mydriasis, dilatation of pupil, constipation, dryness, urinary retention. You close all the faucets, anticholinergic, right? And blockade of serotonin receptors, that's important for atypical antipsychotics, second generation. So how they manage the negative symptoms? Because the presynaptic blockade of the serotonin receptors, you are going to increase the dopamine receptors, dopamine release in the mesocortical area. So increasing dopamine in the mesocortical area, that relieves the negative symptoms, and increase the dopamine in the nigrostriatal area, that may reduce or decrease the extrapyramidal side effects. That is the advantage of second generation. They increase dopamine in the mesocortical, nigrostriatal, they decrease the extrapyramidal side effects. But the problem is they may have metabolic adverse effects like weight gain, and hyperglycemia, cardiac problems, and so that's mainly metabolic adverse effects with the second generation antipsychotics. Second generation, they block dopamine and serotonin. They are mainly effective both positive and negative symptoms. Okay, and the major adverse effects: serotonin blockade, anxiety, and insomnia. All right, so here we can see how this blockade, for example, each drug, for example, clozapine, atypical antipsychotic, mainly alpha blockade. So less sedation, less muscarinic blockade, less CPS. Whereas haloperidol, highest extrapyramidal side effects. Flufenazine, highest extrapyramidal side effects, right? Whereas aripiprazole, very least EPS, least muscarinic blockade, least autonomic problems. So just to compare and contrast using this table. So you don't need to memorize this one, all right? It's a time for quiz. Okay, so how do antipsychotics cause Parkinson's-like symptoms? Pause the video, come up with the correct answer. I think you got the correct answer. That is a blockade of dopamine receptors in the nigrostriatal pathway. We know that nigrostriatal pathway is important for the movement and coordination, initiation of movements. When you disturb or any disorder in the dopamine, the nigrostriatal pathway, that leads to movement problems, mainly Parkinsonism. Which antipsychotic agents are more effective at treating negative symptoms? So that is a both positive and negative. So that is mainly atypical antipsychotics. They block both the dopamine receptors as well as 5-HT, 2A and 2C receptors of serotonin. So they act effective both positive and negative. How do antipsychotics cause orthostatic hypotension? That is blockade of alpha-1 adrenergic receptors. Because so once you block the alpha-1, it decreases the GQ, decreases calcium phospholipase C protein kinase C, and decreases contraction, hypotension. All right, so let's talk about the clinical uses of antipsychotics. The antipsychotic drugs are agents to reduce the psychotic symptoms and improves the behavior of schizophrenic patients. That is the major clinical indication, right? So especially the typical antipsychotics, they may reduce the positive symptoms by tightly binding to dopamine receptors, by blocking the dopamine receptors mainly. So they are mainly effective to reduce the agitation and auditory hallucinations and grandiose paranoid delusions. Everything will be reduced and managed with the typical antipsychotics of the positive symptoms of schizophrenia, including hyperactivity, visual ideation, hallucination, delusions. And typical antipsychotics not effective against negative symptoms. So the beneficial effects may take several weeks because the antipsychotics, they act like time dependent. So when you initially give, you are blocking the dopamine. It's a body thing that there is a compensatory increase of dopamine. Then slowly depolarize blockade of dopamine. Then finally, after months and years of treatment, there is a super sensitivity of dopamine receptor that leads to tardive dyskinesia. All right. So here the atypical antipsychotics like olanzapine, clozapine, They both positive and negative symptoms of schizophrenia controlled by atypical antipsychotics, including emotional blunting and social withdrawal, like especially the clozapine mainly reserved for the refractory cases, because the clozapine it may cause the blood and hematological toxicity like granulocytosis. So you have to frequently monitor the complete blood count. Whereas the risperidone mainly the hyperprolactinemia, increased prolactin, that is a classic with the risperidone in addition to other adverse effects. And also the antipsychotics, so we can use the schizoaffective disorder, bipolar affective disorder, and even the bipolar depression with quetiapine and luceridone, olanzapine, and also antipsychotics used to control agitation, especially in the bipolar disorder and schizophrenia. All right, so what are the other indications? So other indications, especially these are also used in the mania, Tourette syndrome. So what is the Tourette syndrome? So that means it is a abnormal tics and abnormal use of disgusting words. So this is uncontrolled, involuntary, rapid movements like vocalization and tics. So this is a mainly Tourette syndrome. We call it as a Gilles-Della Tourette syndrome. So because the Gilles-Tourette syndrome, so the disorder is named for the Dr. George Gilles de la Tourette, the pioneering French neurologist who is in 1885 the first described the condition in 86-year-old French noblewoman. The simple motor tics are sudden and brief repetitive movements that involve in the limited number of muscle groups. Molindone can be used mainly exclusively to treat Tourette syndrome. So Tourette syndrome means, so here you have some abnormality in the dopamine, right? So maybe, so that increased dopamine, you give the dopamine blocker, so you are going to reduce those abnormal movement tics, right? Huntington's means Huntington chorea. So there is an increase of movement, so dyskinesia movements. So there you can block these the movements by haloperidol, and also you can use tetrabenazine for the Huntington chorea. And also the antipsychotics like risperidone, aripiprazole, atypical antipsychotics can be used to manage irritability, behavioral discontrol in the autism spectrum disorder. So non-psychiatric indications. So non-psychiatric indications like especially antiemetic. So sometimes you cannot control the nausea, vomiting by ondansetron or metoclopramide. So we can use anti-psych medications like prochlorperazine solely for to control the vomiting. So how it is useful? Because we know that in the CTZ chemoreceptor trigger zone, we have dopamine receptors. If you activate these dopamine receptors in the CTZ, so there is a severe nausea and vomiting. Okay. So when you give the dopamine blocker, so you are going to control the nausea and vomiting. Whereas H1 receptors, so that mainly causes sedation and increased appetite. You can use antipruritic sedation, right? So diphenhydramine causes nice sedation, right? By crossing the hypothalamus and block the H1 receptors, produce sedation. It also increases appetite, increases weight gain. And this slide exclusively for the clinical uses of atypical antipsychotics, second generation antipsychotics. So these are as atypical antipsychotics. They are preferred first line because they control both positive and negative symptoms of schizophrenia, and also the acute management of psychosis and anxiety disorders and refractory depression. And also they are mainly used in the management of acute mania, maintenance treatment of bipolar, and also it augments the mood stabilization along with the lithium. When they take the lithium, it takes longer time to produce a response. When you combine with the lithium and these medications, they augment the lithium effect and prevent the postpartum mood episodes due to lithium slow onset. And also it controls the agitation associated with bipolar schizophrenia. We have long-acting intramuscular injections, ziprasidone, olanzapine, aripiprazole. So in some patients, they don't want to take the oral medication, then we can give the injection form. It produce long duration of action. And also, you don't need to give every time the pill, right? So that will improve the patient compliance and better treatment outcomes. Clozapine mainly reserved for the resistant psychiatric disorders because it requires frequent lab monitoring about the hematological complete blood count. And clozapine, the classic adverse effects are granulocytosis. How the patient is presenting a granulocytosis when you decrease the WBC, right? So when you decrease the white blood cells, you are decreasing the white blood cells. Granulocytosis means so less white blood cells. That may leads to more infections and less immunity, right? So atypical antipsychotics also can be used in the Tourette syndrome, and also we discussed about the irritability, behavioral dysfunction control in the autism spectrum disorder. The main drugs, risperidone or aripiprazole, is FDA approved for this disorder. All right, so that we covered the clinical uses, classification, the mechanisms, pharmacokinetics, and potency, affinity in this video. In the next video, I'm going to cover the adverse effects and summary, and that is your most important thing. And thank you guys. See you in the next video.